My dear colleagues, I'm Professor Korkmaz Dilmen from Istanbul University, Cerrahpaşa, Turkey. I'm a member of the Examinations Committee Part 1 subcommittee for about 5 years. I'm also scientific promoter of the Basic and Clinical Science Anesthetic course. I declare no conflict of interest. I'm going to talk about neuroanatomy, neurophysiology, and anesthetic management for neurosurgery. The central nervous systems involves cerebral hemispheres, diencephalon, brainstem, cerebellum, and spinal cord. Hemispheres interconnected by corpus callosum. Each hemisphere is composed of 5 lobes: frontal, parietal, temporal, occipital, and insular lobes. The central sulcus separates the precentral motor cortex and postcentral somatosensorial cortex. The Broca area is the motor speech area, and it is located in the inferior frontal gyrus. The Wernicke area is located here, and the occipital lobe involves the visual area. Any tumors, such as low-grade gliomas, that are located in the motor cortex or Wernicke or Broca areas, are generally undergoing surgery with awake craniotomy to reduce the risk of postoperative neurological problems. The diencephalon has 3 components. The thalamus acts as a gatekeeper for cerebral cortex. The epithalamus consists of the pineal body and choroid plexus, and the hypothalamus regulates the stress response, metabolism, and reproduction through various hypothalamic axis and the hypophyseal portal system. The basal ganglia are a group of nuclear masses of gray matter. It has caudate nucleus, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. The basal ganglia are a part of the extrapyramidal motor system. They communicate with the thalamus to fine-tune motor sequence. Limbic system has 3 components. The hippocampal formation involves the long-term memory. The amygdala is the one responding to fear, and the mammillary body is the last component of the limbic system. The function of the limbic system is the control of emotion, olfaction, and hemostasis. Midbrain, medulla oblongata, and pons produce the brainstem. The respiratory and cardiovascular centers are located in the brainstem, and several nerves are emerging from the brainstem. The oculomotor nerve, the trochlear nerve, emerging from the midbrain. The trigeminal nerve, the abducens, the facial, and the vestibulocochlear nerve emerge from the pons. The hypoglossal, glossopharyngeal, and the vagus nerve emerge from medulla oblongata. The spinal cord extends from the foramen magnum to the level of L1 or L2 in adults. It consists of 5 segments: cervical, thoracal, lumbar, sacral, and coccygeal segments. A total of 31 pairs of the spinal nerves emerging out of them. The cerebellum consists of 3 parts: a middle vermis and 2 hemispheres. The functions of the cerebellum include coordination, precision of motor activities, and motor learning. Let's summarize the circulation of the central nervous system. We need to start with the circle of Wills. The circle of Wills is the anastomotic loop and provides potential for collateral blood flow between the anterior and posterior circulation. The anterior circulation is provided by a carotid artery and the posterior is provided by the vertebral arteries. The middle cerebral artery is the branch of the internal carotid artery, and also here the anterior cerebral artery. This is another branch of the internal carotid artery. There is anterior communicant arteries between two anterior cerebral arteries. Two vertebral arteries produces the basilar artery, and posterior cerebral artery is a branch of the basilar artery. There are posterior communicant arteries between the MCA, middle cerebral artery, and posterior communicant arteries. Let's look to the venous circulations of the brain. Venous circulation is provided by the sinuses, and this is superior sagittal sinuses, this is inferior sagittal sinuses. The deep structures of the brain, venous drainage is provided by the vein of Labbe, and the outflow comes to the sigmoid and transverse sinuses and then goes to the jugular vein. There is also a cavernous sinuses in the pituitary fossa. Its location is very important regarding the hypophyse surgeries. During the transsphenoidal or macroscopic hypophyse surgeries, any injury of the carotid sinus can cause severe bleeding. During our neurosurgery practice, following the pinhead holder placement, we have to give a proper position to the neck with the neurosurgeon. Over rotations or over extension of the neck can cause jugular vein obstructions and blockage of the jugular venous outflow. It may cause raised intracranial pressure. Those sinuses are very important regarding the craniosynocytosis surgery. Any injuries of them can cause severe bleeding, even venous air embolism, although if your patient is in the spine position. Let's look to the circulation of the spinal cord. One anterior and two posterior spinal arteries and radicular arteries supply the spinal cord. Radicular arteries are branches of the aorta. The Adamkiewicz artery is the largest radicular artery and segmental feeder of the thoracolumbar region. It arises from between T6 to L3. A rising level is important during the abdominal aorta surgery, abdominal aorta aneurysm surgeries. Regarding the level of the cross clamping, if the cross clamp is at the higher levels and Adamkiewicz artery is arise from the higher levels, it may cause anterior spinal artery syndrome. Additionally, it also may cause acute kidney injury by blockage of the kidney perfusion. Let's continue with physiology. I would like to start with the neural action potentials. Well, as we all know, various ions, including sodium, potassium, and chloride, are unequally distributed between the inside and outside the cell. In a neuron, in its resting state, the concentration of the sodium ions is higher outside the cell than inside. The relative concentration of potassium ions is the opposite. This different distribution produces a chemical and electrical gradients. The potential difference present across the cell membrane when no stimulus is occurring is called as resting membrane potential. As you see here, the membrane potential is on the y-axis and time is on the x-axis, and the normal resting membrane potential is minus 70 millivolt. As you see, the normal duration of the neural action potential is just 1 millisecond. This is very important regarding the ADA exams. Joanna will summarize the cardiovascular physiology. Please note that the properties of the cardiac action potentials, and you have to know the differences between the neural and cardiac action potentials regarding the part 1 and part 2 exams. And after a stimulus, sodium enters to the cell and membrane potential increases up to minus 55 millivolts. This point is threshold potential. Threshold potential is the membrane potential that must be achieved for an action potential propagated. The first two portion of the curve demonstrates a rapid rise in membrane potential up to peak of plus 30 millivolts as voltage-gated sodium channels opens and allow rapid sodium entry into the cell. The first three shows rapid repolarizations as the voltage-gated sodium channels close and potassium channels opens, allowing potassium efflux. Because of the potassium channels are a little slow to close, for a brief period, the membrane potential is hyperpolarized. It is more negative than resting potential. This is fast forward. And the sodium-potassium pump restores the chemical gradients, but by putting the sodium and potassium in place, and the pump reestablishes the potential gradients. There are two types of refractory periods. The first one is, as you see here, the green side of the action potential is the absolute refractory period. Absolute refractory period is a period of time when no stimulus will elicit a further response. It corresponds to increased sodium conductance. The relative refractory period, this side of the action potential, is a period of time when a larger than normal stimulus may result in a response. It corresponds to the period of increased potassium conductance. We speed up transmission through a process called saltatory conduction, in which the action potential appears jump along the axon covered by the sheath. There are small gaps between Schwann cells called node of Ramvier. The action potential jumps node to node, speeding transmission. The human brain represents about 2% of the body weight, but receives almost 50% of cardiac output. This high flow reflects its significant metabolic demand. Almost 20% of the total body oxygen consumption is used by the brain. The normal value of the oxygen consumption is about 3.5 milliliter per 100 gram brain tissue per minute in adult. Glucose is the primary substrate of the brain metabolism. Approximately 60% of cerebral energy consumption is used to support electrophysiological functions, and the 40% is used to cellular hemostasis. Cerebral metabolic rate is calculated by consumption of oxygen in 1 minute, and the normal value is 3 to 3.5 milliliter per 100 gram brain tissue per minute for adults, and in children it's higher, almost 5 milliliter per 100 gram brain tissue per minute. An increase in neuronal activity and cerebral metabolic rate is proportionally matched by increase in cerebral blood flow. This physiologic process is referred as flow metabolism coupling. In general, all anesthetic agents suppress cerebral metabolic rate with the exception of ketamine and nitrous oxide. The component of cerebral metabolic rate related to basic cellular hemostatic activities is unaffected by the anesthetics. In contrast to the anesthetic agents, hypothermia decreases the rate of energy unit utilization associated with both electrophysiological activity and also basal maintenance of cellular integrity. Cerebral metabolic rate decreases by 6 to 7% per degree Celsius of temperature reduction. Hypothermia can cause complete suppression of the EEG at about 18 to 20 degrees centigrade. Cerebral blood flow is proportional to cerebral perfusion pressure and inversely proportional to cerebral vascular resistance regarding the own rules. And cerebral perfusion pressure can be calculated mean arterial pressure minus intracranial pressure. The global cerebral blood flow is almost 50 milliliter per 100 gram brain tissue per minute, and it is higher in the gray matter than white matter because the neuron bodies are located in the gray matter and they need higher metabolic activity. Several factors are influencing the cerebral blood flow. As I mentioned, cerebral metabolic rate and cerebral blood flow are proportional. And now I'll give detailed explanations about the autoregulation, about effect of PO2 and PCO2 on cerebral blood flow. The optimum blood viscosity regarding cerebral blood flow is achieving when the hematocrit level between 30 to 35%. This knowledge is important, especially for the subarachnoidal hemorrhage cases, especially in the vasospasm stage, to improve perfusion. Autoregulation is the ability of an organ to regulate its blood flow despite change in its perfusion pressure. The brain has a strict autoregulation. As you see here, the cerebral blood flow is on the y-axis and mean arterial pressure is on the x-axis. And when mean arterial pressure 50 to 150 mm mercury, the cerebral blood flow is constant. Actually, this is a textbook knowledge, and in some textbooks, the upper and lower limits of the mean arterial pressure is given by 70 to 130 mm mercury. But nowadays, we know that each person has a own autoregulation curve, and each patient's lower and upper limits of the autoregulation curve is changing. That's why during in our neuroanesthesia and neurointensive care practice, we generally try to find that patient autoregulation range to keep the mean arterial pressures to sustain enough cerebral blood flow. There are some monitoring tools such as PRX index and also cerebral oximetry are using to determine the lower and upper limits of the autoregulation range. And as we all know, chronic hypertension shifts that curve to the right. According to myogenic hypothesis, change in cerebral perfusion pressure directly influence alterations in vascular smooth muscle tone independent of extrinsic factor. As you see here, during hypotension, the diameter of the cerebral vessels increase, resistance of the cerebral vessels reduce to sustain enough perfusion. During hypertension, the resistance increase and the diameter of the vessels reduce to prevent hyperemia. Trauma, inflammation, seizures activity, and conditions causing raised ICP may abolish autoregulation. But recent studies show that these circumstances does not completely abolish autoregulations. they narrow the zone of autoregulations. That's why if the autoregulation is sustaining in a narrowed zone, if we can keep our patients' mean arterial pressures in that zone, we may improve our patients' outcome. At normal condition, cerebral blood flow has linear relationship with PCO2 between 20 to 80 mm mercury. For each change of 1 mm mercury in PCO2 from normal values, cerebral blood flow changes 1 to 2 ml per 100 gram brain tissue per minute. Although changes to cerebral blood flow induced by PCO2 are rapid, they are not sustained. Despite maintenance of arterial pH, cerebral blood flow returns to baseline over 6 to 18 hours due to cerebral CSF pH gradually normalizes through bicarbonate extrusion. Let's look at the effect of PO2 on cerebral blood flow. We always try to keep the PO2 values in a normal range because below a PO2 of 60 mm mercury, hypoxia causes cerebral vasodilations and rising cerebral blood flow and intracranial pressure. On the other side, hyperoxemia causes severe vasoconstriction and it may cause cerebral ischemia. Regarding the vasoactive agents, we do not use nitroglycerin, nitroprusside, and nicardipine as an antihypertensive in our neuro-ICU and neuroanesthesia practice because they have direct vasodilator effects, and vasodilation increases the blood volume inside the cranium and it may cause elevated intracranial pressure. That's why we generally prefer beta blockers such as esmolol. They have minimal effect on cerebral metabolic rate and cerebral blood flow. And let's look at the effect of anesthetic agents on cerebral physiological parameters. As you see here, all inhaled anesthetics reduces the cerebral metabolic rate and increases cerebral blood flow and increase the intracranial pressure. As you see here, the halothane has the highest effect. Regarding intravenous anesthetics, all intravenous anesthetics reduces the cerebral metabolic rate and cerebral blood flow and also intracranial pressure, except ketamine. Ketamine, regarding the textbook knowledge, ketamine increases the intracranial pressure. But ketamine also an NMDA receptor blocker. It blocks the glutamate effects. And glutamate is the major excitatory amino acid of the central nervous system, and it triggers several pathophysiologic cascades, such as following traumatic brain injury. Ketamine also can block the cortical speeding depolarizations. That's why recent publications show that ketamine may have some favorable effects in brain injury cases. And this year, during neuroanesthesia, there is a debate, and I will summarize the beneficial effects of ketamine in TBI. But regarding the academic exams, we generally ask for textbook knowledge. That's why if you see any option that ketamine increases intracranial pressure, you have to choose the correct option. Regarding opioids, they have minimal effects on neurophysiological parameters. That's why we generally prefer remifentanil-based anesthesia during neurosurgery. Let's look to cerebrospinal fluid. It's produced by the choroid plexus of lateral ventricles. Then it goes to the third ventricle by foramen Monro. Then goes to the fourth ventricle by aqueduct. Then pass to the foramen Monro and Dushka and Magendie to goes to the subarachnoidal space. The normal volume is 150 milliliter for adults, and the production rate is 500 milliliter per day, or 0.35 milliliter per minute. Regarding the composition, we need to know the composition of the CSF for part 1 exam. You can see several options that compare the CSF to plasma. As you see here, the osmolality and sodium concentrations are same in the CSF and plasma. Potassium level is lower in the CSF, and carbon dioxide level is higher compared to plasma. That's why CSF is more acidotic compared to plasma. The glucose and protein concentrations are lower compared to plasma. This last knowledge is very important to meningitis diagnosis. The blood-brain barrier consists of pericytes, astrocytes, and tight junctions between the endothelial cells that structure permeable to respiratory gases, substances of molecular weight less than 30 kilodalton, and impermeable to large polar and lipid insoluble substances. In adults, the rigid cranium essentially forms a fixed brain volume. The contents of this fixed brain volume are the brain parenchyma, cerebrospinal fluid, and the cerebral blood. Therefore, brain tissue mass, CSF volume, and cerebral blood volume will determine the intracranial pressure. As you see here, this is the normal intracranial pressure trace. The normal value is between 10 to 15 millimeter mercury in adult. But following a hematoma, accumulations of the cerebrospinal fluid, or abscess, tumors, edema can cause midline shift and rapid rise in intracranial pressure. In the cranium, change the volume of any of one component will alter the other or one or more components of the cranial contents. We call that the Monro-Kelly doctrine. And rise in intracranial volume can be compensated up to one point. But after that point, rise in volume causes rise in intracranial pressure and reduction in cerebral perfusion pressure and may cause herniation. That's why in our neuropractice, we always try to increase intracranial compliance. Now, I would like to give you an example. In the first case, the blood pressure is 110 to 8 millimeter mercury. If we calculate mean arterial pressure, diastolic blood pressure plus pulse pressure divide 3, it is 90. If our patient have a normal intracranial pressure, for example, 10 millimeter mercury of intracranial pressure, we can calculate the cerebral perfusion pressure via mean arterial pressure minus intracranial pressure. It's 80. It is enough for normal subject. Let's think about our cases has a raised intracranial pressure, such as intracranial pressure increases 30 millimeter mercury. But also, if our patient has a light hypotension, as you see here, blood pressure reduced 110 to 90 to 80 millimeter mercury. If we calculate the mean arterial pressure, it's 70 minus 30, it's 40. 40 is not enough for for us. That's why even slight hypotension can cause reduction in cerebral perfusion pressure if your patient has raised intracranial pressure. Okay, how can we measure intracranial pressure? There are some non-invasive and invasive techniques. Optic nerve sheath diameter measurements is a non-invasive technique, and if optic nerve sheath diameter more than 6 mm, it shows us the rise intracranial pressure. But in our clinical practice, we generally use electrodes to measure invasive intracranial pressure. We can use epidural, intraparenchymal, subarachnoidal, ventricular, or subdural electrodes. But in our clinical practice, we generally prefer use of ventricular catheters because they provide cerebrospinal fluid drainage. That's why we can use that catheters as a treatment option. That patient was admitted to our intensive care unit following the head trauma. As you see here, there is a ventricular catheter and there are two transducers here. Please note that the transducers are located at the level of tragus, at the level of middle cerebral artery to measure cerebral perfusion pressure. The one transducer belongs to mean arterial pressure. The other one is using to measure intracranial pressure. And as you see here, if ICP is high, we can drain cerebrospinal fluid in that cap. And that vital signs belong to the same cases. The first line shows us the arterial pressure, the second line is intracranial pressure, and the third one is cerebral perfusion pressure. As you see here, between the 9th quarter to 10, that patient's intracranial pressure increasing gradually up to 59 millimeter mercury. And additionally, blood pressure is increasing up to 231 millimeter mercury. But as you see here, cerebral perfusion pressure is constant. How can we treat that case? Please note that if you give any antihypertensive drugs, you may abolish cerebral perfusion pressure. That's why. What should we do? We drain just 10 milliliter of cerebrospinal fluid. As you see here, intracranial pressure reduced up to 24 millimeter mercury, and the systolic blood pressure reduced itself. We didn't give any antihypertensive drug up to 119 millimeter mercury. And please note that cerebral perfusion pressure increased. If we can't reduce the intracranial pressure, the brain goes to herniation. Okay. Let us adapt this anatomical and physiological knowledge to our clinical practice. We will start with the anesthetic management for supratentorial and infratentorial mesh surgery. At the preoperative assessment for the supratentorial mesh surgery, besides the systematic evaluations, neurological state of the patient should be determined. The patient orientation, speech deficit, Glasgow Coma score, and muscle power should be assessed. Besides this, CT and MRI should be evaluated at the preoperative assessment. As you see here, supratentorial mesh surgeries can be done for just the small meningiomas or for giant GBMs. The size and localizations of the tumor is very important. The tumor would be localized on the eloquent area. That's why those patients would need awake craniotomy, and some tumors would be near to the major vessels. Signs of elevated ICP should be assessed at the preoperative images. Effacement of the lateral ventricle by the tumor mass, and also midline shift more than 5 mm are the signs of raised ICP. Besides this, brain edema should be assessed, and those patients need steroid treatments. And generally, brain tumors, if they cause the intracranial edema, are need steroid administrations. As we all know, steroids has some side effects such as hyperglycemia. Hyperglycemia increases the risk of infections and also risk of gastrointestinal bleeding and surrenal suppressions. For prolonged periods steroid administration, sometimes we cannot deal with intraoperative hypotension with just fluid resuscitations or vasopressor administrations without administer hydrocortisone if your patient has surrenal suppressions. Additionally, meningiomas and metastases can be associated with significant blood loss. And malignant tumors and immobility increases the risk of thromboembolism. That's why mechanical precautions such as compression socks treatment should be started at the early postoperative periods, and administration time of the low molecular weight heparin should be decided with collaboration of neurosurgeons. Let's look to infratentorial space. It consists cerebellum, midbrain, pons, medulla, and the fourth ventricle. At the preoperative assessment, the images are very important. Those patients can come with hemangioblastoma, such as here. Some of them are children in infratentorial tumor surgeries. Generally would be kids, such as posterior fossa ependymoma, cerebellar metastasis, and polycystic astrocytoma would be undergoing infratentorial craniotomy. At the preoperative assessment, lower cranial nerve paralysis should be assessed by gag reflex, because absence of the involvement of the lower cranial nerves can cause absence of gag reflex at the preoperative period and some swallowing problems. It may cause silent aspiration pneumonia. That's why we need to check the X-ray, CRP, and also leukocyte levels at the preoperative assessment. Some infratentorial tumors are undergoing surgery in the sitting position. That's why to detect the patent foramen ovale, preoperative echocardiography should be done, because if the foramen ovale is patent, when any venous air embolism may cause paradoxical air embolism. And for supra and infratentorial craniotomies, we need to avoid the preoperative sedation if there is the sign of elevated intracranial pressure. Sedation can cause hypoventilations, and that's why accumulation of PCO2 and rise intracranial pressure. Anticonvulsants and steroids should be continued at the perioperative period. Besides standard ESA monitoring, invasive arterial pressure and urine output monitoring is used in patients are undergoing craniotomy. The invasive arterial blood pressure transducer should be localized at the level of the tragus to measure correct cerebral perfusion pressure. this patient is undergoing surgery in the sitting position, that the correct transducer location is here. And we routinely use BIS and proceeded ECG monitoring to reduce the risk of postoperative neurocognitive decline, especially in elderly population. That monitoring is also really useful to titrate the dose of propofol infusion in somatosensorial and motor evoked potential monitoring patients. As you know, we do not administer neuromuscular blockers in that patients. That's why a proper level of the hypnosis is very important. Cerebral oximetry is a very useful method to detect acute intracranial hypoxic events, especially in aneurysm surgery during clipping. The critical regional cerebral oxygen saturation can be defined as lower than 55%, but the trend is more useful than an absolute value. Preoperative transcranial Doppler is used to determine the level of vasospasm in ruptured aneurysm. I'll give detailed explanation soon. And precordial Doppler and T are using to detect venous air embolism if patient is undergoing surgery in the sitting position. We prefer using multi-orifice central venous catheters for just sitting positions to aspirate any possible air embolism. Beyond all this, the anesthesiologist must be observed the surgical field. If there is a brain bulking, ventilation strategy and anti-edema treatment should be arranged. In general, our general principles of anesthesia involve avoidance of hyper or hypoxemia, avoidance of hypercapnia, and providing hemodynamic stability. Surgical manipulation of the brainstem structures can cause severe hemodynamic response in posterior fossa surgery. Interruption of the surgical stimulus and administration of antiarrhythmic drugs may be necessary. Enough depth of anesthesia should be arranged by BIS and proceeded ECG guidance. If the surgery is performed with neuromonitoring, the total intravenous anesthesia is using and neuromuscular blockers are contraindicated. If inhaled anesthesia is administered to antagonize the inhaled anesthetic-induced vasodilations, we can apply mild hyperventilation, and the concentration of the inhalation anesthetic should be less than 1 mg to reduce the inhaled anesthetic-induced elevated intracranial pressure. Regarding the pain treatment, generally infratentorial craniotomies are more painful than supratentorials. We routinely use scalp nerve blocks for intra and postoperative analgesia. 2 mg per kilogram, 0.5% bupropion, and it can be applied in 3 milliliter injection on zygomaticotemporal, supratrochlear, supraorbital, auriculotemporal, minor and major occipital nerves. And supine, lateral, and prone positions are using in supratentorial craniotomies. The over-rotation, flexion, and extension to the neck can cause venous outflow obstruction and a rise in intracranial pressure. During intraoperative period, to prevent elevated ICP, evolumia should be sustained. Head-up position is important. No compression of jugular veins are sustained. And if there is an elevated ICP, or if drained tumors are undergoing or drained hematomas are undergoing surgery, you may administer osmotic agents. mannitol or hypertonic saline are options, but in my department, we generally prefer hypertonic saline because mannitol administration can cause severe hypovolemia and some cardiac arrhythmias. Regarding hypertonic saline administration, we generally prefer 20 to 30 milliliter per hour infusions during 2 days or 3 days perioperative period. We do not prefer bolus hypertonic saline administration because bolus administrations can easily cause hyperchloremia and it may lead to the acute kidney injury. And we have to continue steroids for brain edema. Adequate hemodynamics should be sustained, and we need to avoid the hypoxemia and hypercapnia. If during the surgery, if brain bulking developed, the surgeon can drain the CSF to improve the venous drainage. As an anesthesiologist, we can check the head positions and we may reduce the level of PEEP. And osmotic agents can be administered. Mild and short-term hyperventilation can be used, and augmentation of the depth of anesthesia reduces the brain metabolic rate. It would be helpful. And the pack bench, prone, and the sitting positions are using in infratentorial craniotomies. The similar to supratentorial, we need to prevent venous outflow obstruction while giving position. Sitting position has some advantages and also some disadvantages. Sitting position provides optimum access of midline lesions, improves venous and CSF drainage, decreases ICP, lowers airway pressures, and also lowers bleeding. But the main problem is embolism. It may cause venous or paradoxical air embolism. It may cause hemodynamic instability. That's why we need to administer bolus crystolite before giving position to prevent hypotension. It may cause pneumocephalus, peripheral neuropathy, macroglycia, and if you don't give a proper position, it may lead to spinal cord injury at the cervical level and even tetraplegia. There are some factors that may contribute to occurrence of the severity venous air embolism. The posterior fossa, where venous channels are stand open surrounding structures. The extent of the head elevations and negative pressure between the right atrium and surgical side can increase the risk. That's why volume should be sustained, and low central venous pressure may increase the risk of venous air embolism. The most sensitive monitor for detection of venous air embolisms are T and Doppler. And reduction in end-tidal carbon dioxide has modest sensitivity. As we know, pulmonary embolism causes dead space ventilations. That's why end-tidal carbon dioxide reduce and arterial carbon dioxide increases. And what are the complications of venous air embolism? Intraoperative period, we can see dysarrhythmias, hypertension, EEG, evidence of ischemia, acute right ventricle failure, even cardiac arrest. And it may cause hypercapnia, hypoxemia, pulmonary edema, and pulmonary hypertension. And if there is a patent foramen ovale, it may cause paradoxical aortic embolism. And at the postoperative period, some patients may need transient, non-invasive or invasive mechanical ventilations and also cardiovascular support. How can we treat venous air embolism? At the intraoperative period, you need to inform the surgeon immediately. Then if you use nitrous oxide, nobody uses nitrous oxide nowadays, but if it is using, discontinue it and increase oxygen flow. The surgeon have fluid the surgical field with fluids and close the leakage by Bomax. Provide jugular vein compressions to surgeon can easily define the leakage place, and we need to aspirate the right arterial catheter. It may cause severe hypotension and some arrhythmias. The patients may need cardiovascular support. And if we can't deal with the venous air embolism with that precautions, the patients can be turned to left lateral decubit positions. Fluid therapy for supra and infratentorial craniotomy is our main aim is providing normal volemia and normal osmolality, because hyperglycemia worsens the consequences of cerebral ischemia, and hypoosmolality, as we all know, increases brain edema. That's why we avoid to use glucose-containing and hyperosmolar solutions during neurosurgery. To maintain volemia, pulse pressure variation and stroke volume variation monitoring are very easily useful techniques. And as I told you, we are giving crystalloids loadings before positioning of sitting position to prevent hypotension. Now I'll talk about the subarachnoidal hemorrhages. More than 80% of cerebral aneurysm arise from the anterior and posterior communicating and middle cerebral arteries, with only 10 to 20% arising from the posterior vertebrobasilar circulation. Different grading methods are used in subarachnoidal hemorrhage. The World Federation Neurosurgeon scale is based on Glasgow Coma score and the presence of focal neurological deficit. The hand and head classification evaluates the patient's neurological status after subarachnoidal hemorrhage. And the Fisher grade is based on the blood on the CT scan, and higher grades associated with higher vasospasm and higher mortality risk. In the grade 1, as you see here, there is no subarachnoid blood detected. In the grade 2, a diffuse or thin vertical layer less than 1 millimeter thick of blood is detected. In the grade 3, localized subarachnoid clots or a vertical layer more than 1 millimeter thick of blood is detected. In the grade 4, intraventricular or intraparenchymal clot or diffuse or no subarachnoid hemorrhage is detected. Aneurysms are generally bleeding when transmembrane pressure gradient increase. There are two determinants of the transmembrane pressure gradients. This is the difference between the mean arterial pressure minus intracranial pressure. Sudden severe hypertension or sudden reduction in ICP can increase transmembrane pressure gradient and may cause rebleeding. There are several complications that associated with subarachnoidal hemorrhage. The most important and early complication is rebleeding. The maximum risk of rebleeding is the first 2 to 12 hours. Most of rebleedings are occurring at the first 7 to 2 hours of initial hemorrhage. Early securing of aneurysm by coiling, as you see here, by coiling or clipping, is the treatment of choice to prevent rebleeding. To prevent rebleeding, our guideline is advising reduction of systolic blood pressure less than 160 mm mercury by nicardipine, labetalol, or osmolar administration. But aggressive management of blood pressure, yes, reduces the risk of rebleeding, however, at the expense of an increased secondary ischemia. That's why identify the patient autoregulation state and which level of mean arterial pressure is sufficient for that patient is important. In that cases, nowadays, pulse PRX index and also cerebral oximetry indexes are using to calculate the lower and higher limits of the cerebral autoregulation range. The second important complication is vasospasm. Vasospasm commonly occurs 3 to 5 days after initial hemorrhage, with peak vasoconstriction occurring between the 5 days and second week. It may manifest in many features such as reduced conscious level or focal neurologic deficit. Under the pathophysiology, oxyhemoglobin stimulates production of endothelin and it causes vasospasm. Transcranial Doppler is a non-invasive method to diagnosis of vasospasm. Progressive increase in mean velocity flow rates is predictive for vasospasm. If MCA mean velocity rate more than 120, this is the indications of vasospasm, and we also use the Lindegrand ratio. We are using the mean MCA velocity rates ratio to ipsilateral internal carotid artery velocity rates. If that ratio higher than 3, that indicates the vasospasm. Symptomatic clinical vasospasm is only often seen at mean velocities of 160. And although this, the gold standard for the diagnosis of vasospasm is still conventional angiography. The treatment of vasospasm, we always use nimotropin. Nimotropin, the single drug that proven the efficacy for prevention and treatment of vasospasm. We generally use enteral route because IV administration can cause severe hypotension. If patients are undergoing surgery for clipping, due to surgical irrigation of blood, that reduces the risk of the vasospasm compared to interventional neuroradiology embolization cases. If vasospasm is detected by angiography or transcranial Doppler, transluminal angioplasty or papaverine administration can be used for treatment. Hypertension and euvolemia should be sustained by neurointensivists, and hemoglobin level should be kept between 9 to 10 grams per deciliter to sustain enough blood viscosity and cerebral blood flow. Although we can prevent vasospasm, in some cases we cannot prevent delayed cerebral ischemia. Delayed cerebral ischemia has a different pathophysiological mechanism. Nowadays we don't know the real underlying mechanism, but inflammations and some microthrombosis and cortical secreting depolarizations can be triggered delayed cerebral ischemia, and low molecular heparin weights or some anti-inflammatory drugs are administering to reduce the risk of delayed cerebral ischemia, but we need further researchers in that area. We have also some cardiac complications following subarachnoidal hemorrhage, such as ECG changes, increase in troponin levels, myocardial regional wall motion abnormalities, and Takotsubo cardiomyopathy. Cerebral salt worsening can be seen with hypovolemia. during the administration, beside the fluid resuscitation and sodium administration, we need to use fludrocortisone that blocks the urine output of the sodium. And during the intraoperative period, we need to focus on preventing rebleeding and factors. We need to avoid the factors that precipitate vasospasms. We need to prevent sudden increase in blood pressure and ICP, and rapid decrease in ICP may cause rebleeding. That's why if you administer mannitol, that can be given after draw open to prevent rise in transmural pressure gradient. There are temporary clips, and this is the permanent clip. Control hypotension facilitates surgical clipping. Temporary vascular clips are used to interrupt blood flow, and it may, if the duration of the temporary clip placement prolongs, it may cause a neurological injury. That's why we routinely use SEP and MEP monitoring in our department to prevent this. Induced hypertension provides collateral circulations when temporary clips was applied. And in some centers, such as in Finland, and we also used in our some cases, transient cardiac pulse can be used with adenosine for giant intracranial aneurysm clearance. AVMs cause intracerebral hemorrhage, especially in younger generation, bleeding most commonly between the 10 to 30 years of age. At the pre-operative assessment, the combination with high blood flow and low vascular resistance may cause cardiac failure. Radiological embolizations and surgical clipping, surgical excisions are treatment options. At the intraoperative period, we need to apply controlled hypotension to control bleeding. And at the postoperative periods, cerebral hyperemia can be seen due to perfusion pressure breakthrough syndrome. Okay, when we extubate our cases, if the patient Glasgow Coma scale more than 9, if there is no intraoperative lower cranial nerve involvement, it's detected by neuromonitoring. If there is no extensive intraoperative brainstem manipulation with a great likelihood of brainstem injury, if there is no hemodynamic instability and no intraoperative major fluid shifts, early extubation provides immediate neurological assessment and earlier indications for further investigations. At the last part of my presentation, I talk about the pituitary adenomas. As we know, the pituitary gland is located in the sella turcica. There is optic chiasma and carotid arteries are on the upper side, and cavernous sinus and carotid arteries are located in the each lateral sides. The anterior pituitary gland is producing growth hormone, adrenocorticotropin stimulating hormone, thyroid stimulating hormone, gonadotropin hormone, and prolactin. Posterior side is producing antidiuretic hormone and oxytocin. The symptoms of the pituitary adenomas are related to hormone secretions and their mass effects. If at the anterior pituitary adenomas, if the adenome secretes the prolactin, it may cause galactorrhea, amenorrhea, and infertility. If the adenome secretes adrenocorticotropin hormone, it causes Cushing disease. If growth hormone is secreting, it may cause acromegaly or gigantism in adolescents. If there are non-secretory hormones, and if there are some supracellular tumors such as craniopharyngioma, Radke-Kleffkis, they involve the pituitary glands, they may cause mass effect and panhypopituitarisms and visual symptoms. The mass effects are optic tract effects, headache, nausea, diabetes insipidus, papilledema, and ischemia. Acromegaly can cause difficult ventilations and difficult intubations due to large lips, tongue, skin shrinks, bony hypertrophy, prognatism, thick skull, jaw, hands, and cervical spine changes, airway obstructions, and laryngeal narrowing. Cardiomyopathy is the most common mortality reason in acromegaly cases, and in Cushing disease, oversteroid causes diabetes mellitus, hypertension, left ventricular failure, airway obstructions, and skin problems in patients. The clinical feature of hypopatriotism include reduction in adrenocorticotropin hormone secretion causes low cortisol levels. That's why hypovolemic shock and hypovolemia. Reduction in thyroid stimulant hormone causes hypothyroidism, and posterior hypophysis, if affected, it may cause diabetes insipidus due to reduction in antidiuretic hormone secretions. The clinical features is polyuria, low urine osmolality, hypernatremia, and hypovolemia. The treatment involves desmopressin and fluid replacement. Surgical techniques, multiple transcranial, sublabial, or transsphenoidal endoscopic. Nowadays, generally all centers are using transsphenoidal endoscopic approach. TIVA or inhaled anesthetics can be used. The pituitary gland is the lower side of the cranium. That's why light rising intracranial pressure may facilitate the surgical achievement of the tumor. That's why we need to apply normovolemia, normocapnia, even sometimes hypercapnia. And spinal catheters are using to pumping saline into the CSF to increase the intracranial pressure to facilitate the surgical achievement of the pituitary gland. In some circumstances, surgeons can damage to the dura mater, and to treat the dural injury, we are using spinal catheters to treat CSF leakage. At the last part of my presentation, I summarized the spinal surgery. As we all know, generally those patients are undergoing surgery in the prone position. While we are giving positioning, we need to avoid the abdominal compressions to reduce the vena cava pressure and prevent vertebral venous engorgements and bleeding. We also need to avoid the thoracic compressions to allow easier ventilations in the prone position. Post-operative visual loss is a very important complications of the prone position, especially in prolonged procedures if your patient has diabetes, hypertension, and anemia. We need to avoid the inhaled anesthetics and neuromuscular blockers in patients are undergoing surgery with electrophysiological monitoring. And blood loss is another issue. We generally administer transamine for high segments reconstruction surgeries to reduce the bleeding. Some centers are using acute normovolemic hemodeletion and intraoperative cell salvage techniques. To postoperative pain control, in recent years, generally non-steroid anti-inflammatory drugs are avoiding to favor of their effect on osteogenesis, but nowadays we know that at least 1 week administration of non-steroid anti-inflammatory drugs does not cause any problem in the fusion surgeries. That's why to facilitate the opioid sparing effects, we generally use paracetamol and non-steroid anti-inflammatory drugs. Intraoperative ketamine infusion can reduce the risk of postoperative chronic pain, but we also know that ketamine can cause the beta burst on procedure ECG. If you are using dense spectral array monitoring, ketamine may interfere with your results. In my center, we generally use intravenous opioids, intravenous analgesia at the postoperative period because epidural analgesia can cause some motor blockage and may postpone the diagnosis of surgical complications. I didn't mention the awake craniotomy and pediatric neurosurgery due to lack of time, but I would love to answer your questions and share my clinical experience in that subjects. Those are my references, and of course the Kotra and Miller anesthesia neuroanesthesiology sections are excellent parts, and I will be waiting your questions. My dear colleagues, this is an example about part 1 exam concerning supracnoidal hemorrhage. The option A, more than 80% cerebral aneurysm arises from cerebrovascular circulation. The option B, maximal risk of vasospasm is the first 2 to 12 hours. The option C, cerebral angiography is the gold standard for the diagnosis of vasospasm. The option D, cerebral soul worsening is the complication associated with supracnoidal hemorrhage. And the option E, nitroglycerin can be administered as an antihypertensive to reduce the risk of rebleeding. Thank you very much.